Hello, welcome back to our podcast, Hypermobility Haven, with me, Amanda Carey.
And me, Holly Graham.
Both final year BSc physiotherapy students at the University of Brighton.
As we have previously mentioned, none of the information you'll hear in this podcast is professional advice, more just ideas and what we've learned about these conditions as student physiotherapists. If you want any further information about anything we have discussed, please contact your GP or your primary caregiver.
So in this episode, we're going to be talking about joint hypermobility and the differences in the new classification for hypermobility spectrum disorder and hypermobility Ehlers-Danlos syndrome, and to help you navigate all of the research and the changes to the classification.
So we're going to start off with what is hypermobility. So hypermobility is defined as a condition in which someone has abnormal range of movement. So this could be due to many different things. So it could be bone shape, it could be the amount of collagen you have, or it could be down to connective tissues. So this doesn't always have to be symptomatic. So some people will have hypermobility or a form of hypermobility and have no symptoms whatsoever throughout their lives. Other people, it can have quite a debilitating effect and can cause them a lot of symptoms, pains and troubles throughout their lives.
Okay, Holly, so what you're saying is that whilst hypermobility itself refers to excessive joint range of motion, it's not necessarily a dysfunction or a disorder in and of itself.
No, so not so much. So like I said, some people have a lot of symptoms, others don't. So there can be things like joint subluxations, dislocations, sprains, injuries, joint pains. A lot of people with hypermobility struggle with joint pains, especially around their back and around their pelvis. But like I said before, this doesn't always affect everyone. So the difference between a bendy disorder is that the connective tissue is weak and it can't withstand the forces that go through that tissue.
Okay, so having sort of hypermobility or overly flexible joints doesn't mean necessarily that someone has good muscle length. And again, people with hypermobility disorders will generally overcompensate for joint instability by reducing their range of movement. And that means basically that muscles can be tight despite joint instability or excessive range of movement.
Yes, so people tend to almost get stuck within that range of movement due to fear of overextending because the connective tissue is weak, and they might be aware due to past experiences that this could lead to things like subluxations and dislocations.
Okay, and then that could also in turn affect their posture, and then that might impact on other structures in the body, put more stress on those, and then there's a vicious cycle.
Yeah, so it's kind of like a snowball effect. Once one thing starts to happen, they start to compensate for something else, which could cause, in turn, a lot of different symptoms that go alongside with hypermobility.
Okay.
So hypermobility spectrum disorder is something new that's only really been around the last few years. So a new classification came around in 2017, which basically said that joint hypermobility is a whole spectrum, and it allowed a larger population of people who have similar yet different symptoms all fit into a condition, allowing them to feel a bit more validated. So before, it was just known as joint hypermobility, and people wouldn't really know what that meant or where to go with it. And now it's a complete different spectrum, so it links all of your different symptoms together to make people understand them a bit more.
Okay, so just to point out that the new classification that came in 2017 was actually brought out by the International Consortium of hEDS, who are a global group committed to sort of research and collaboration for people facing these sorts of challenges. And they came up with this hypermobility spectrum, recognising that while some people might be able-bodied, others might have serious levels of disability.
And also to note that there is a classification for hypermobility spectrum disorder, but it's still not widespread, like rolled out across all different clinics and throughout the NHS just yet. As it's still new, it's in the process of being validated and making sure that this is definitely the right way to go with all of the research. So the Ehlers-Danlos Society actually have a really lovely diagram which helps understand the hypermobility spectrum. So this is just saying how person 1 could really suffer with joint instability, pain, fatigue, what else, headaches, anxiety, etc. However, person 2, who also still is within this hypermobility spectrum, might have mast cell activation syndrome, gastrointestinal issues, dysautonomia, a little bit of anxiety, a little bit maybe less pain or more pain. So they still fall under the same HSD umbrella, but they present completely differently.
Okay, so it's worth considering the issues of combining different sort of people across the spectrum. For example, a double-jointed gymnast or a chronically disabled patient with hypermobility disorder are going to present very differently. Also, a dancer is going to need a certain level of stability if they're a ballet dancer compared to someone who's trying to be a contortionist, for example, in Cirque du Soleil. So that's why the spectrum exists, although it does obviously need some fine-tuning. It does actually acknowledge the different needs and issues presented by each of these different groups.
So hypermobility spectrum disorder can be broken down into 4 different almost subcategories. So there's generalised hypermobility, which is where you have hypermobility in multiple joints all over the body. So this could be shoulders, elbows, knees, hips, wrists and ankles, etc. There's peripheral hypermobility, so that's where you're only hypermobile in your hands and your feet. Localised hypermobility, which is a single joint or a group of joints within the same area. So that could be, for example, just your shoulders, or it could be your wrist and hand. And then there's historical hypermobility, which is where you used to be hypermobile, but not so much anymore. And then these are all thought to have been inherited, but they might not always be. So they could be triggered from things like trauma. So a previous joint dislocation could then cause hypermobility at that joint. Or it could be due to a joint disease such as Ehlers-Danlos syndrome. Or it could be from how your connective tissues heal after a surgery, for example. And it also depends on what sex you are. That could determine your likeliness of getting hypermobility. So males tend to be less prone to HSD, but it is still a possibility. This is due to them having higher testosterone levels and lower estrogen levels. So estrogen increases your ligament and tendon flexibility, as well as males, alongside their testosterone, also have more lean muscle mass around a joint, which will support it and in turn hopefully reduce likeliness of symptoms such as subluxations. It's also being researched at the minute that small mutations in several genes can be what makes someone bendy, and this spectrum can be created from a variety of genes being mutated, and things such as how you exercise and your nutrition right from when you're a child up to however old you are at the minute can all link to your connective tissue and make their problem and cause them to have problems. So it's also thought to be inflammatory, which is where the exercise and nutrition comes into it. A lot of things such as sugars are seen as to be very inflammatory. So it depends on what you're eating to how your body will react to this. And I believe, you can correct me if I'm wrong, Amanda, because you've been looking into Ehlers-Danlos a lot more than I have, but that is a very similar way that it has come around, in sense that it's very, part of it is very genetic and it's inherited from a family member.
Yeah, so they're still not sure about the biomarkers for Ehlers-Danlos syndrome, but hypermobility Ehlers-Danlos syndrome is the most common type. There's 14 types in total, some of which are considered to be quite rare. But Ehlers-Danlos syndrome is the most common hereditary disorder of connective tissue. So we're going to talk a bit more actually about Ehlers-Danlos in particular, as we know that many of the people that Joe works with have got Ehlers-Danlos syndrome. And there's also obviously an issue, or has been an issue for many people, around the diagnostic labels and, you know, how important that is in terms of whether or not they have EDS or if they have something else relating to the hypermobility spectrum disorder. And really looking at EDS, we're kind of looking at that heritable factor. So probably genetically heterogeneous sort of disorder, but we don't have unequivocal proof demonstrating that they carry the same genetic sort of trait. And that's still sort of an ongoing process of research.
Okay, so what are the similarities between hypermobility and Ehlers-Danlos syndrome?
So typically they relate to either symptoms and or signs of dysfunction. So symptoms would typically include things like dizziness, headaches, vomiting, and signs might be a rash, something visible like that, or, you know, excessive bruising, stretching of the skin, changes in blood pressure as well. And hypermobility, as you've already said, could be localized, peripheral, or generalized in both circumstances. But also a 5-point questionnaire, which was developed in 2003, also takes into account the historical information. So it could be, you know, have you ever had any of those symptoms in the past? Not necessarily that you're having those symptoms now. I've been looking a lot and listening to the Bendy Bodies podcast with Dr. Linda Bluestein, and she tends to have lots of different doctors, people who specialise in EDS, fascia, and also movement therapy. And she gets them to come onto the podcast to discuss how people can manage their symptoms better. So one of the podcasts, recent one, was with Dr. Wang, so Dr. Tina Wang, a fascia researcher, and she was talking about myofascial pain, because that's referred pain, which a lot of people with EDS tend to experience. The fascia is altered in people with hypermobility spectrum disorder and EDS, and it envelops the nerves, vessels, and muscles. It also includes our tendons, ligaments, and the brain. So it's really not difficult to imagine that the organs can't function properly if connective tissue or fascia is affected.
For those that might not know, can you explain a little bit what actually is fascia and what role does it play?
So again, it's the connective tissue, as I say, but it envelops like a web. It envelops the tissue, the muscles, and so on. And it needs to be properly loaded for you to avoid injury. So it has different qualities to muscle. Obviously, muscle's the only thing that can really move the body, but fascia needs that resilience. It needs adaptability. For example, if you're, on an uneven surface and you roll over on your ankle, you need to have that elasticity and that ability for that tissue to bounce back so that you don't get injured.
So the fascia is almost like an elastic band where it has the recoil of where it's meant to stretch and then come back together to help, when, say, you roll an ankle, for example, to help bring your tissues back to where they're meant to be.
Definitely, yeah. And that's really affected in EDS in particular, but also Dr. Wang was saying that it could possibly also be the originating organ that's affected in connective tissue disorders. So it's not necessarily that the EDS has caused that. It might be that the fascia itself has caused the EDS, but we don't know. But it definitely plays a very big role. And I think a lot of people, there's not enough kind of focus on the fascia, because usually that's often the damaged element when someone injures himself. It's not necessarily the muscle. But there are different exercise routines out there that focus on strengthening the fascia by stressing the tissue in a full range of movement. So in a full contraction, concentrically, where the tissue gets shorter and contracts, but also where you're loading the tissue eccentrically as well. And you're also loading it in lots of different ranges of movement and different directions. So it's like a multi-directional type of movement that you'd be looking at for that. And the Zebra Club, which I know a lot of Jo's clients that she's worked with, a lot of people that follow Jo's work, they also use the Zebra Club app. That's with Jeannie DeBon, and she really focuses on the fascia and its role in connective tissue disorders. And there's also art of motion training, which I've done some training in that, and that's also focusing on the fascia, not specifically for hypermobile people, but it does a similar, if you actually look at a lot of the resources, it does a lot of similar things that the Zebra Club.
Well, I was actually about to say that working on the fascia and working on strengthening all the way through that range of motion will also be really helpful for those with hypermobility to understand their body and understand the whole range that their joints can go through, and where it's safe and where they might not be as strong as they originally thought they were, and where they need to work on.
Definitely. Well, what's good about the Zebra Club is that the focus, you have a very tailored program. So it is a virtual program, but that can have its benefits as well, because obviously you can do it from your own home. You don't have to get dressed, go out, and those things can obviously trigger symptoms with hypermobility disorders. But also you can focus in your own time as well, and you can pace the classes as much as you want, stop and start. But you focus on the breathing, relaxation, stability, proprioception, balance. You focus on those key aspects before you even start to move, really. So that's what's really good about that program. The program I'm talking about as an alternative, which is through Art of Motion, they have a lot of free resources actually on YouTube. You might want to start more with one of theirs that's a little bit more basic, so they do like relaxation of the tissue, that kind of thing. Because a lot of the time the tissue it could be that it's hypertonic, so it could be that it's over stressed, and actually the first thing you might want to do is think about relaxation and breathing before you go into some of the more complicated sequences where you're obviously loading the tissue.
Well, it's also about when you're going into movement and exercise and things like that, just learning. For a lot of people, especially with hypermobility, they don't trust their body. They're worried that if they move or they exercise, something's going to happen to them and they're going to get injured, or they're going to sublux a joint, for example. So if they start as simple as breathing and using the right breathing technique when they start to move, they'll hopefully begin to trust their bodies more. And then the more they trust their body, the more they'll be able to build up gradually and do more as time goes on. I think especially using resources like you've just mentioned, Amanda, that you can do from the comfort of your own home, so you don't have the external anxiety of everyone else you might feel looking at you or being around other people. You can do what you feel is best for you at your own pace.
I think definitely that's one of the key aspects of exercising in a virtual way. Obviously you lose that element of having like a group, that kind of motivation that some people kind of benefit from. But I think what's really good about working virtually is that you can set goals that are realistic. So it might take you might say, okay, there's 5 principles behind the training, and I'm going to take 5 weeks to get my body to kind of learn those techniques before you actually start doing the exercise sequences. Whereas you wouldn't necessarily get that much time if you were going to a group class in real time in person, because you'd be relying on everyone else being at the same sort of level as you or going at the same pace. And some people might have different learning needs and they might need to learn a bit slower as well.
Yes, I agree, because it's almost like you can have, for example, 1 week or a whole session to focus on one concept that you really want to grasp, that will help, that you might struggle with, to help you move on further. But then if you are in a group setting, different people want to focus on different things and move at different paces, and as much as the instructor or the leader might try and tailor it to each individual, unless it's an individual like one-to-one, it's very difficult to try and keep everyone at the same level focusing on the same thing, because everyone has their own strengths and weaknesses. And I think that links it back to how it's a whole spectrum of how everyone has their own symptoms and manages them and struggles with them differently.
Definitely. So one of the symptoms that might be different between individuals is pain. And if you have pain, then there's going to be a certain amount of breath holding going on as a coping strategy. But obviously that is then going to have a negative kind of impact somewhere else in the body. Whereas someone else, if pain isn't their sort of primary symptom and it's more fatigue, then they might actually be okay with the breathing side. But maybe they just struggle with the pace of the class. And maybe they might find the balance element a bit harder, for example. Maybe they're really good at lying and relaxing and doing that element, but they find the standing and the balancing element more challenging. So they might spend more time looking at that side of things.
Or even to link it back to, you said someone might have pain. It's two people might have pain, but they might hold their stresses and their pains differently in their body, and it could refer to a different pain somewhere else, for example. So pain, I think, is a horrible topic. I personally think that it's very interesting, but in a sense of, you read something and you feel like you've got to start all over again with learning about it. I don't know if I'll ever fully understand everything there is behind pain. I think it's just very complex, but what you can try and, the easier bits to grasp is the pain you're feeling somewhere might not always be the site that it's coming from. So for example, you could have hip pain that is resulting from poor pelvic floor management. So just looking at your hip and trying to fix your hip might not always be the answer.
Yeah, definitely. So that goes back to the referred pain that we were talking about, which also thinking about the myofascial pain is the referred pain. And that's why it's really important to treat the person as a whole rather than just focusing on the site of pain, for example, the shoulder, that you're actually looking at the person holistically, which requires probably working with a variety of different professionals once you've found the right people who that you can communicate well with, who you feel are listening to you. They're not medically gaslighting you, which is another thing we've been, that comes up a lot in these sorts of conversations. People that don't believe the symptoms that you're telling them. You're the best person who can tell someone else about your pain and what's happening in your body, and also what is the best way to manage your symptoms. What eases those symptoms, what aggravates those symptoms, and also those are really good ways of finding out how someone can actually help you and what strategies you can use. So don't be afraid to actually go with a list of all those things to an exercise practitioner or a physiotherapist or occupational therapist and say, these are the things that I've worked out, because that's all detective work that they don't have to do.
Definitely. I also think you need to create a village around you, like Amanda said, of different healthcare professionals and people that A, you trust, and B, want to work collaboratively to help you, and what management strategies work best for you, because it might not be the typical thing that you see online, or it might not be the perfect thing that works for everyone, but if it works for you, that's all that matters. And especially, it might not be the first person that you go and see. It might take you 3 or 4 or 5 attempts to find the right people. But once you've found the right team that all want to work together and help you, I think honestly it's a game changer. It can really benefit both your physical and your mental health and well-being.
Definitely, and the best thing is to keep people informed of any changes that you might have to symptoms. We will be talking in another episode about the different comorbidities that come up, with these conditions, as there are many comorbidities, which also could change at any point, and that will change the symptom management as well. But the other thing to really highlight here is try not to wait until you get injured for you to start thinking about how you're moving and the impact of how you're moving on your joints. Have a think about early on how you can use different strategies to try and prevent injury. So seek guidance from people like Joe, but also some of these podcasts. Bendy Bodies is a really good resource. If you find that a little bit too medicalized or scientific, there's also the Natasha Littman podcast, has a lot of interesting information, and also just generally reach out to different people, such as Jeannie DeBon on the Zebra Club, just to get some guidance really about how to manage the different symptoms you're experiencing.
I also think, just to add to that if listening to a podcast might not be the perfect idea for everyone, it might get too overwhelming. You might need to see it physically in front of you. Looking at charity websites such as Ehlers-Danlos Society, they have a plethora of information on there, and it really helps you understand and come to terms with what the condition actually is. And there's lots of lovely visual pictures on there that help you see it in a different way.
Definitely, the Ehlers-Danlos Society has a lot of free resources. I mean, generally what you want to try and gather is access to as many good quality and up-to-date resources as possible, and ask yourself what the goal of that resource is. Is it there to help people? So when you're looking at research into the subject, is it there to advance people's knowledge about the condition, or is it just there for the sake of research? So, you want to be able to kind of trust in all the resources you're looking at and reading, and know that there is actually hope to kind of manage the condition a little bit better in the future, and actually, cope with all of the different comorbidities as well, and recognise that there are a lot of other symptoms beyond just the hypermobility component, because a lot of those are being ignored by health professionals.
Yeah. So both Ehlers-Danlos and hypermobility use the Baton scale as one of their diagnostic measures. This is one of the most common ways used in different clinics and practices, and it's used with five different points. So it's done to test the range of movement at joints. So the first one that typically gets done is you would have a hand flat on a surface, and you would see if you can lift your pinky finger up to either 90 degrees or past 90 degrees. And if you can do this, you would get a point for each hand you can do it on. So each pinky finger would be worth 1 point. The second aspect is thumbs. So can you get with your arm out straight and your palm facing down, you want to bend your wrist downwards and touch your thumb to your forearm. So you want the side of your thumb to be flat against your forearm. And again, that's 1 point for each thumb. The next point is your elbows. So if you extend your elbows out in front of you, is there more than 10 extra degrees past straight? So do your elbows go past a straight line when they're fully straight as far as they can go? The next one, and that is a point for each elbow again. And the next one is your knees. So when you stand with your knees locked back straight, is there again more than 10 degrees past a straight line where your knees go, and as all the others, 1 point for each leg. And the final one is your spine. So that's if you bend forwards, can you place both of your hands flat on the floor without bending your knees? And if you can, that's 1 point. So all of this adds up to 9 points. And if you have 5 or above, you're considered to have hypermobility, but this changes with age. So I believe the score goes down as you get older. So I think I can't remember the age range off the top of my head, but at some point it goes down to 4, things like that. So...
Is that due to the connective tissue changing?
Yes, over time.
Over time, yeah.
So the Baton score has its pros and cons. So a good thing about the Baton score is that anyone can really do it, give it a go, see what they feel, how they feel. Or even if you was at home and you thought, oh, I could have this, you might be able to try some of these things. Also, you might be able to do these and think it's normal. A lot of people think some of these things are normal when it might be linked to another comorbidity or condition or something such as hypermobility or Ehlers-Danlos syndrome. But then it only looks at four or five joints. It only looks at 4 areas in that. So you've got your hands, your elbows, your knees, and your spine. So a lot of people with hypermobility struggle with their shoulders, but this doesn't actually look at the shoulders whatsoever.
And the hips as well.
And the hips, yeah, exactly. So, yeah, it's a bit... I'm unsure how I feel about it, to be honest. I think it's a good almost stepping stone as almost a first, we think it could be this. Like, let's see how you do on the Baton score, but then equally, you could score a 0 on the Baton score and still have localised hypermobility to your shoulder, and the Baton score won't pick it up because it doesn't look at the shoulder.
Mm-hmm. So is it more that the individual clinician might look at your whole body in terms of all the different joints, and also particularly where you might be getting symptoms? So if you had pain, for example, or discomfort or subluxation, dislocation in a particular joint, that's the area that they might focus on, so that they bear in mind the 9-point Baton scoring system as a sort of starting point, but then they kind of do other tests. So it's not meant to be a standalone test, and also originally it's actually meant to be for research purposes. It's not actually meant to be a clinical tool. It's just been used as a clinical tool over a long time, just in the absence of a better tool, as far as I understand. But obviously there's also historical information that's really important and plays into people's, into diagnoses. And also, as I say, looking a little bit more in depth at different symptomatic areas.
Yeah, I definitely don't think it would be beneficial to be used alone in a sense of, you scored on the Baton score, here you go, here you have hypermobility. There's so much more that goes alongside it, and so many different areas that the Baton score might not cover or might not be specific enough into what is causing this. So, for example, Amanda and I were having a conversation earlier about the spine area of the Baton score, how there's other components adding into whether you can actually touch your hands flat on the floor without bending your knees. It's not all about your spine. It could be muscle tightness in the hamstrings, for example, that could prevent this from happening, but you might still be hypermobile. I hope that makes sense.
Yeah, so often what happens is, because we've talked already about this, about compensatory patterns, so particularly in EDS, people are struggling to find that stability. So what sometimes happens, and I've noticed it in my own Pilates classes, I can see people are tilting their pelvis back, so going to a posterior tilt, which actually shortens the hamstring. And they're doing that to provide some stability to their pelvis. I'm not saying that's right or wrong per se. It's more, if they were then to do a test, they wouldn't score in the Baton score, they wouldn't score any points, even though actually it could be that they had some hypermobility within the spinal joints, but they wouldn't necessarily, it wouldn't show up in that test. Also, if you put your hands on the floor and let's say you've got hypermobile elbows, then you're locking your elbows anyway. Often people have kind of quite poor upper back posture as well. So this is just the general population from sitting at desks and stuff. So they tend to sort of hunch forward. Again, there's so many factors when you do a spine stretch forward. Even if you're sat with your legs in front of you and you ask someone to touch their toes. Someone years ago said to me, "Oh, you've got great hamstrings." And I thought, actually, my hamstrings are tight, but I knew that my spine was very flexible.
Mm-hmm.
And that was a personal trainer. And at the time, I wasn't a fitness instructor. And I thought, that's weird that they're saying that to me because I know that my hamstrings are tight. So sometimes you also, as I've said before, you know your body the best. So you can also give whoever it is looking into all of these things, you can give them that extra information.
I also think that's a very good point of how you know your body the best. You know exactly how you're feeling and how that feels. As much as you can try and explain to someone, I don't know, you're in pain that's affecting your sleep or your daily activities, or you going to the shop, for example, as much as you can say something to a clinician or a healthcare professional, they're not feeling it, they're not experiencing it. They can note it down and take it into account, but you're the one that knows, actually, no, this is going to trigger me. This isn't the right thing for me to do.
Yeah. And also that actual test itself would be highly triggering for a lot of people. Asking someone, they might not have tried to touch their toes for years, and you're asking them to potentially lose stability, bend down, if they've got POTS type symptoms, which we'll talk about in another episode, but where you might feel lightheaded, they're not going to want to put their head down. So they're going to go into a compensatory pattern because of that fear of bringing on symptoms.
Especially those people that seem to tense up with their fear as well. They might think, oh my goodness, I can't do this, and freak themselves out before they've even attempted the task, which could in turn lead them to not be able to do it when they might have a hypermobile spine or a hypermobile in another joint that's trying to be assessed, but because they're holding themselves so tense with this fear, it's not showing off what's really going on per se. That they can't avoid doing it, but it's learning the strategies, like we've spoke about earlier, of tackling this.
Definitely. And also it remains a huge barrier for people, the Basin scale, it remains a huge barrier for people to be denied an accurate diagnosis for, in particular, hypermobile Ehlers-Danlos syndrome. So there does need to be an awareness around the other tools and other measures and other observations and a knowledge by the practitioner of the features of these particular conditions, but also comorbidities and how that might present. And sometimes, unfortunately, it might take the person with that condition to actually go with write down a little list of exactly how, what features have come about as a result of that condition, because it might be that they're not a specialist in that area, and the worst thing for you is to feel disheartened when you come out of that appointment and then lose faith in the medical profession as a whole, just because of and it might not be their fault. They might not just be a specialist in that area. You can't be a specialist in every area, and it takes a wider understanding of learning, and hopefully this criteria that's come in 2017, hopefully that gradually can now start to make a lot of practitioners and clinicians a bit more aware of hypermobility spectrum disorders. Okay, so to summarise, because we've had a lot of different information we've been talking about, different aspects of these conditions, if we're looking at it from the perspective of differentiation between EDS and HSD and the controversies around diagnosis, there was a really, really useful podcast by Bendy Bodies with Dr. Alan Hakim, episode 110. And that actually, he talks about the new classification and how that merges, joint hypermobility and EDS within a different criteria. But actually, really, the spectrum disorder is just a better way to describe what's been around for a long time, approximately 20 years. He says 70% of hypermobility is heritable. As we know, hEDS excludes acquired connective tissue disorders. That's the main difference. And also that EDS has a musculoskeletal element as well, strongly associated with lower back pain and other musculoskeletal elements. Also a good point here that he makes is, we're looking at fibromyalgia and chronic fatigue syndrome. These are also other aspects that are associated with these conditions, and they're part of the comorbidities, but they're not part of the criteria. However, Hakim does acknowledge Dr. Hakim acknowledges the need to remodel the criteria, and he is conducting a prospective study, which means a study on people in the future, looking at people with HSD, hEDS and chronic pain to see whether we can tell the differences between those three conditions, that would give a baseline from which that we could then look at biomarkers and test those on these populations. And this would mean that we could have a clear test for an hEDS diagnosis rather than it being something that's based on exclusionary factors. So the key thing he really says is what we need to question is it part of the inflammatory process or not? These symptoms, these features, are they part of an inflammatory process? And also, can we differentiate other primary diseases that might be at play? Sometimes people also have lupus, rheumatoid arthritis, for example. Just because you have EDS doesn't mean you can't have those things, but we also need to identify whether or not that person has those things, because those things need to be managed in their own way.
Yeah, and I feel like research like this is really exciting and important for the whole community of people that have hEDS or HSD or any other conditions surrounding that are similar and are in a similar process, because it almost turns an exclusion criteria into hopefully an inclusion criteria. So instead of being like, well, you don't have this, it will be, okay, so let's look at this symptom you've got, this is how you're feeling, you've got this, this and this. Okay, we've done whatever tests, we think you have EDS or we think you have hypermobility. It almost, I think, brings that sense of validation of, oh, like this is what I have, where a lot of people, when it's an exclusion diagnosis, could be like, might feel, I don't really know, they've given me this, I don't really know what it means or how it affects me. Whereas with more of an inclusion diagnosis that hopefully these biomarkers will bring, people will understand more, okay, I have this, this and this means I have hypermobility, or I have Ehlers-Danlos, or I have fibromyalgia, so on. So yeah.
And it is important, because another good point that Hakim mentions is that sometimes people just automatically put it down to having EDS, when actually it might be to do with something else. They might say, oh, that's my EDS, or the consultant might go, well, that's your EDS, when in actual fact it isn't. It's actually something else that needs to be resolved. And so that will give the opportunity for that to happen, and people can get the proper treatment that they need and the proper respect and also attention that they need for the different conditions that they have.
Absolutely. Well, I think that's enough information for this one episode.
I think so. I think we'll leave it there for today. Thanks for listening.